We want to call the Select Committee on Infectious Diseases and High-Risk Disadvantaged Communities public hearing, informational hearing to order this day, Monday, July 25th, 2016. My name is Mike Gibson. I serve as the chair of the Select Committee on Infectious Diseases and High-Risk Disadvantaged Communities. I want to welcome each and every one of you here to be part of this very robust conversation. We are here to discuss the recommendations and strategies for battling HIV and AIDS epidemic here in California. I want to also thank in advance the panelists for making themselves available, for joining us here this afternoon. I want to thank the University of San Diego for allowing us to be here. It's a beautiful campus, and I had the opportunity to see much of it because I was lost. So I do apologize. I certainly like to start meetings on time because we realize everyone's schedule is very cumbersome. So in today's hearing, we will be giving an overview around HIV and AIDS in California, as well as information on preventative medication that can reduce the individual's risk of contracting HIV. We will also hear recommendations for increasing awareness and uptake on those medications that are now made available to us. In 2014, there were approximately 122,000 people in California living with HIV and AIDS. This disease has particularly affected minority communities with high rates in the African American community and large numbers of new infectious cases among the Latino community. The work of advocates and healthcare workers, patients, and policymakers cannot be counted out of this discussion. It's very important that we bring everyone to the table to have this in-depth conversation. The National HIV and AIDS Strategy was released in 2010 and provides the nation with directions and directives on HIV services. Other states such as New York, Massachusetts have developed a statewide plan, but California has not done so. And it is certainly our desire to bring people together to have a robust conversation and create our own strategy so California can be counted among those progressive states that will address this growing epidemic. The State Office of AIDS is currently planning meetings to discuss laying the foundation for getting to zero new infectious cases in California. By holding this hearing, I am proud to stand with you to bring about progressive and develop such a strategic plan. For those in the audience, we will have two separate opportunities for questions and answers. During the question and answer section, please, we ask you to step up to the microphone, provide us your name and name of organization if you represent an organization, and your comments and questions will certainly be addressed by the panel that's up here today. I also want to recognize my fellow elected officials who give them opportunity. My colleague, Member Waldron, an opportunity to say a few words and to also participate in this very robust conversation. So with that, let me begin to ask Assembly member who represent this area to open up with a few words of her own. Thank you very much. Let's give her a round of applause.
Thank you, Chairman Gibson. I was still living in New York back in the early 80s when the knowledge of AIDS and a few years later HIV came to light. And the knowledge was actually extremely limited. The history of HIV and AIDS was, when the epidemic began, was in illness, fear, and death, especially in New York and San Francisco areas and LA. In fact, I remember the fear and the ignorance that spurred unwillingness of some hospitals and caregivers to even treat patients presenting with immune deficiency symptoms. And it was much like what we're seeing now with Ebola. It's the unknown, that we deal with. However, with the growing knowledge and transmission and causes of the disease and the development of highly effective antiretroviral drugs, representing a major turning point in allowing people living with HIV to live long and healthy lives. Our mission now is to develop and implement workable solutions in the state of California to end the transmission of the AIDS virus, to reduce the community viral load, and end the stigma on treatments for the disease, both PEP and PrEP, and educate primary care practitioners and clinicians on counseling and treatments of these preventative treatments. So, you know, I'm excited about this, and I know that it's something that we can actually have an impact, so in a positive way. So I look forward to hearing our panelists today. Thank you.
Thank you very much. Let me just walk us very briefly in terms of what has transpired so far. Our first hearing was held in San Francisco last year. At the hearing, we heard from a wide variety of local elected officials and state departments and community-based organizations on how the state can develop a plan. We also learned how the state can best address the needs of disadvantaged communities in implementing such a plan. The second hearing took place in Los Angeles, was held and also in March. At this particular hearing, we began to discuss the varieties of barriers encountered by individuals in their quest to get access to much needed services. The panel discussion was very robust and very interactive and got heated at times around the barriers in which individuals have experience in their prospective communities, and gave recommendations on how to address those barriers moving forward. Today's hearing will focus on another tool that can be used to fight HIV and AIDS epidemics by preventative medication that can reduce the chances of anyone contracting HIV. Now to begin, I would like to welcome Dr. Karen Marks, the Chief of the Office of AIDS within the State of California Department of Public Health, who will provide us with an overview of the status of HIV and AIDS in California and discuss how her office is incorporating all this information and disseminating this information around preventative medications. And that's through their work in the State Department of Public Health. So with that, please welcome Dr. Marks, who will give us her presentation. So thank you very much for being here.
Thank you.
Okay.
Afternoon, everyone. So while this is coming down, I just wanted to take this opportunity to thank Assembly. It's not on. Never hear me again? Is it on? Okay, got the thumbs up. So I just wanted to take this opportunity to thank Assemblymember Gibson and Assemblymember Waldron and their staff for organizing this hearing and inviting me to share the work that the California Department of Public Health Office of AIDS is doing to ensure that all Californians who are at risk for HIV know about and can access PrEP and PEP. So I'm going to start off with giving an overview of HIV in California, and then after that I'll talk a little bit about the work that we're doing around PrEP and PEP. So the California Department of Public Health Office of AIDS has the lead responsibility for coordinating state programs and services relating to HIV and AIDS, including all of the HIV prevention, HIV care work in the state, the HIV treatment work in the AIDS Drug Assistance Program and the Office of AIDS Health Insurance Premium Payment Program, and the HIV surveillance, research, and program evaluation work at the Department of Public Health. This is the big picture of HIV in California. And you can see in the red line the number of new HIV diagnoses in California each year since the beginning of the HIV epidemic in 1981. The green line represents new AIDS diagnoses. The red line, the blue line represents all-cause deaths among people with HIV. And then the gray bars represent the number of people living with HIV in the state. And there are several striking things about this picture. The first is, of course, the rapid decline in deaths in the mid-1990s that was associated with the introduction of highly active antiretroviral therapy or HIV medication. So that really was a turning point in the HIV epidemic. And then we also see a slow decline in new HIV diagnoses in the last 15 years. But we can also see that the number of people newly diagnosed with HIV in the state each year is higher than the number of people dying who have HIV. And as a result, the number of people living with HIV in the state continues to grow. And that pattern will continue until we're able to really bring down the number of new HIV infections occurring each year. This shows the demographic characteristics of people living with HIV in the state in 2014, which is the most recent year that we have surveillance data available. So we can see that they're overwhelmingly male, about 12% female, and about 1% transgender. By risk category, about 75% are gay men and other men who have sex with men. About 7% are injection drug users. And then by race ethnicity, as Assemblymember Gibson noted, there are about 42% white, about 34% Hispanic, 18% Black, 4% Asian, and about 24% Native American, and 2% This is a similar slide, but it shows the demographic characteristics of people who were newly diagnosed with HIV in 2014. Okay. Thanks. Is that better? Okay. So this shows people who were newly diagnosed with HIV in 2014. So this is the leading edge of the epidemic, people who were just recently diagnosed. Again, we see they're about 87% male, about 12% female, about 1% transgender, about 70% gay men and other men who have sex with men, about 4% injection drug users. But then when you look at race and ethnicity, about 44% are Latino or Hispanic. So there are more Hispanics diagnosed with HIV in California now than any other racial or ethnic group. About 29% white, about 17% African American. And then if we look at the age distribution of people newly diagnosed with HIV and living with HIV, we can see in the light blue bars are people who were just diagnosed with HIV in 2014, and in the dark blue bars, people living with HIV. So like most sexually transmitted diseases, we see that most people who are being newly diagnosed with HIV are in their 20s and 30s, but most people who are living with HIV are now in their 40s, 50s, and 60s or above. And that's because people are living full, healthy lives with HIV, but that also means that their care is getting more complex. So we're not just treating HIV anymore, but we're treating HIV in association with other diseases that come with aging. If we look at the states with the highest number of diagnosed people with HIV, we see that California is second in the country after New York. And then we can also look at states with the highest number of new HIV diagnoses in 2014. And California was the state with the highest number of new diagnoses in 2014. And then we can also look over the last 5 years. These are number of new diagnoses in California, which have been slowly decreasing, in New York, which have been decreasing more rapidly, in Florida, that have been stable, and in Texas, which has actually had an increasing number of new cases. Many of you are familiar with the continuum of HIV care. So this is the US continuum of care, which shows that 30% of people, an estimated 30% of people in the US who are living with HIV are virally suppressed. And this is California's continuum of care in 2014. So we have an estimated almost 139,000 Californians who are infected with HIV. 91% of them have been diagnosed. So we are very proud of this in the sense that there is both a nationwide and an international goal of getting at least 90% of people living with HIV diagnosed with HIV. So we have exceeded that in that we have 91% of folks in California who are living with HIV who are diagnosed. And that's so important because in order to access care, you have to be diagnosed with HIV. About 64% of people living with HIV are in HIV care, and about 52% have achieved viral suppression. So that's higher than the 30% nationwide, but of course it's not where we want to be. We want 100% of folks who are living with HIV to have achieved viral suppression. Now, many people often ask why in California are the percentage of people who have achieved viral suppression higher than the percentage who are retained in care, and that just has to do with the federal definition of retention in care, which is at least 2 medical visits at least 3 months apart in a calendar year. And the current HIV treatment guidelines recommend for people who are living with HIV, who've been on medication for a long time, virally suppressed, high CD4 T cell counts, that these people are doing really well and they only need to be seen every 6 months by their physician. And in fact, many doctors in California are seeing those kinds of patients who are doing really well only once a year. So you can imagine if you see your doctor in December and then you see them again in July and then you see them again the following January, that person is going to look like they're not retained in care, even though we know that they are if they're virally suppressed. This is a result of a CDC study that estimated the transmission of HIV at each step of the care continuum. So nationwide, it estimated that about 30% of transmissions result from people who are infected but not diagnosed with HIV, and about 61% from people who are diagnosed but not retained in medical care. And very, very few transmissions are from folks who are in medical care. And this just emphasizes the importance of getting people into medical care and on treatment, and also the importance of making sure that we really work hard to make sure that everyone who's infected with HIV gets diagnosed with HIV and linked into medical care. This shows the continuum of HIV care by gender in California. And the next few slides show by various subgroups, and this enables us to look at health disparities. So we can see that about 57% of men who are diagnosed with HIV in California have achieved viral suppression, but only 53% of women, only 51% of transgender women, and only 47% of transgender men. If we look by race ethnicity, again, we can see disparities. 49% of African Americans and 54% of Latinos have achieved viral suppression, compared with 63% of Asians and 62% of whites. And if we look by risk group, again, there are disparities with people with a history of injection drug use having lower viral suppression than other folks. And if we look by age group, people, younger people, teens and people in their early 20s have the lowest level of viral suppression, and then viral suppression increases with age. So we have a lot of work to do to address these disparities in California. The Office of AIDS has 3 guiding documents: the National HIV/AIDS Strategy, the President's HIV Care Continuum, and California's Integrated HIV Surveillance, Prevention, and Care Plan. And many of you know that we're in the process now of updating our integrated plan. The National HIV/AIDS Strategy was released in 2010 by President Obama with measurable outcomes to achieve by 2015, and then was updated in July of 2015 with updated outcomes to achieve by 2020. It has the same vision and 4 goals, but was updated with key developments since 2010. And the vision of the national strategy is a vision that I think we all share, that the United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care, free from stigma and discrimination. The Office of AIDS goals are aligned with the National HIV/AIDS strategy, the first goal being to prevent new infections, the second to increase access to care and improve health outcomes for people living with HIV, the third to reduce HIV-related health disparities, and the fourth to achieve a coordinated response to the HIV epidemic in California. So some of the key developments since 2010 are what allow us to now really start envisioning getting to zero new infections. So the first of these is the implementation of the Affordable Care Act, and thankfully California has really led the nation in this implementation. This expanded access to preventative services such as HIV testing without a copay or deductible, and also eliminated discrimination against people with HIV because of their HIV status, and that it enabled people with HIV to now purchase insurance, which before ACA implementation was really not an option for people living with HIV. It also increased access to comprehensive health coverage, both through Medi-Cal expansion and through Covered California. Also, since 2010, there are a couple of key studies that were published that show that early HIV treatment reduces the risk of onward transmission by 96%, while simultaneously improving health outcomes for people living with HIV. So it really proved that treatment is the right thing for people living with HIV, immediate access to treatment, and it's also the right thing for the community in preventing HIV. Also, we saw since 2010 the adoption of new HIV testing technologies that enhance the ability to diagnose HIV soon after infection. So this broadens the window of opportunity for effective interventions during acute infection, which is when HIV is most likely to be transmitted to others. And then finally, one of the focuses I know of this hearing today is the FDA approval of HIV pre-exposure prophylaxis, or PrEP, so taking one pill a day to reduce the risk of HIV acquisition by over 90%. So why are we talking about getting to zero now? Well, as I just outlined, the scientific and policy tools now exist in a way that they really didn't before. Modeling studies have shown us that we can end the epidemic by diagnosing HIV rapidly after infection, by testing, and then rapidly getting infected people on treatment and virally suppressed. Modeling has also shown us that increasing the proportion of at-risk negative people on PrEP further improves the rate of prevention of new HIV infections over and above treating people who are HIV infected. And then actual data from California and elsewhere suggests that we are already seeing declines in new infections from increasing the proportion of the HIV-infected population, which is virally suppressed. So we are now, as I mentioned, with this vision of getting to zero, we're now updating California's Integrated HIV Surveillance Prevention and Care Plan. And this is a joint effort between state, local, and community partners, and will set forth California's commitment to collaboration, efficiency, and innovation in order to meet or exceed national HIV/AIDS strategy, prevention, care, and treatment goals. We hope this will provide a vision and foundation for eventually getting to zero new infections in California, and it will include measurable targets to achieve over 5 years, strategies and activities to meet these targets, and resources committed towards implementation. And this is due to our federal funders on September 30th of this year. So I want to just acknowledge the Office of AIDS and local health jurisdiction staff who have provided all those data. And then I want to take a little bit of time to provide an update about the work that we're doing at the Office of AIDS in encouraging full implementation of PrEP and PEP in California. So PrEP is a relatively new FDA-approved prevention tool for people at high risk for HIV acquisition that involves taking one pill a day. The single pill contains 2 HIV medications, and taken daily, PrEP can reduce HIV acquisition by over 90%. Prior to its use as an HIV prevention modality, the same medications were used to treat HIV successfully for over 10 years. And then I always talk to people about the fact that taking PrEP every day to prevent HIV is similar to taking a birth control pill to prevent pregnancy. They're both very effective when they're taken every day to prevent what they're designed to prevent, but they must be combined with condoms if protection against other sexually transmitted diseases is needed or desired. Post-exposure prophylaxis, or PEP, involves taking 3 HIV medications, often combined into a fewer number of pills, starting 72 hours after a potential exposure to HIV, to decrease the risk of HIV infection, and that's continued for 28 days. The effectiveness of PEP has not been as rigorously studied as the effectiveness of PrEP, but it's estimated to be over 80% effective. So PEP is kind of like taking a morning after pill to prevent HIV. The Office of AIDS, in collaboration with local health jurisdictions and many other partners throughout California, using both federal and state general fund resources, has been working on numerous projects to help implement PrEP and PEP use in California. In order to coordinate this PrEP implementation across funding sources and collaborators, we have been working with the Pacific AIDS Education and Training Center to develop a California PrEP strategic plan that will be a key supplement to our laying the foundation for getting to zero integrated HIV surveillance prevention and care plan. Overall, our work is focused around 4 major areas. Patient navigation, which includes educating clients about PrEP and PEP and helping them to access the interventions through a medical provider. Provider education and training, PrEP financing, and developing data and program evaluation systems that will assess uptake of these interventions throughout California, examining potential variations in uptake by population or geography, with the goal that these interventions are available to all people throughout the state who would benefit from them. So we want PrEP and PEP to decrease health disparities, not increase them. So to give a little bit more detail about our work on patient navigation, in fiscal year 14-15, the Office of AIDS was fortunate to receive $3 million in state general fund from the legislature to establish 4 innovative HIV prevention demonstration projects. Our grantees included the County of San Diego, right here, the Los Angeles LGBT Center, and the San Francisco AIDS Foundation. The HIV prevention demonstration projects share an overall focus on HIV testing and linkage to HIV prevention and care services for high-risk underserved populations. These grantees are using a portion of their award amount to provide outreach and linkage to PrEP and PrEP and PEP navigation services. All of the grantees are focusing their outreach and services on California's highest risk populations, including gay and bisexual men and other men who have sex with men, especially MSM of color and young MSM, as well as transgender women. And all are reporting successes with their populations of focus, and they're finalizing lessons learned and best practices to share throughout the state. In fiscal year 15-16, we received $2 million in state general fund from the legislature to be awarded through a competitive request for application process to local health jurisdictions and community-based organizations throughout California, specifically to develop PrEP navigation services. 9 grantees were funded and are currently beginning to implement programs. All of the grantees are developing innovative strategies that will help define best practices for increasing access to PrEP among underserved populations in California. And then in September of this last year, we were awarded $3.5 million from the Centers for Disease Control and Prevention to fund 4 California metropolitan statistical areas determined by the CDC, including San Diego County, Orange, Alameda, and Riverside counties. This funding is designed to facilitate broader awareness, support, and capacity for the scale-up of PrEP services, and to address barriers for men who have sex with men and transgender persons at high risk for HIV infection, particularly people of color. Nationally, only 12 jurisdictions throughout the country received this competitive PrEP funding, and this included 3 jurisdictions in California. Our award to CDPH, Office of AIDS, and also direct CDC funding to Los Angeles and San Francisco. These funds will provide training and technical assistance for navigation and outreach services and develop and distribute educational resources for clinician and non-clinical private providers, local health department staff, community-based staff, and actual consumers. These jurisdictions are using these funds to develop comprehensive models to increase access to PrEP, including establishing PrEP clinics within sexually transmitted disease clinics, partnering with primary care providers who will serve populations at the highest risk, hiring local public health nurses and outreach workers to educate local physicians and medical clinics about PrEP. And then we are also supporting multiple efforts to improve medical and non-medical provider education and training around PrEP and PEP. So these efforts include emailing a Dear Colleague letter to all primary care and infectious disease physicians throughout the state that had important information and training resources about PrEP. We're also in the process of developing California-specific clinical guidelines for PrEP and PEP in collaboration with the CDPH STD Control Branch. We hosted a 2-day workshop for statewide HIV prevention partners, which included information about PrEP and a PrEP consumer panel. And we're working with the California Prevention Training Center to conduct a needs assessment to identify health department and agency training and capacity building needs. We're also updating our basic counselor skills training curriculum, which trains new HIV test counselors within the state to include comprehensive PrEP information in the pre-training packet and an additional module focused on PrEP during the 4-day in-person training. In addition, we're working with our training partner to develop an online continuing education training for existing HIV test counselors. We're working with the developers of pleaseprepme.org, which is an online directory of PrEP clinical providers throughout California, to expand the website to also include a searchable directory of PrEP navigation services throughout the state by either zip code or county. And we're also working with a contractor to develop culturally appropriate educational videos and other materials regarding PrEP designed for the populations at highest risk for HIV, transgender women, and young gay men of color. And then I also wanted to give an update regarding PrEP financing. The governor's enacted budget that was just signed last month includes authority to expand ADAP to provide services to HIV-negative people at risk for HIV by covering prescribed PrEP medications on the ADAP formulary and related medical copays, coinsurance, and deductibles incurred by all individuals accessing PrEP in California with annual incomes below 500% of the federal poverty level. So we are very excited about implementing this new program starting in the spring of 2017. And then finally, as I mentioned earlier, we recognize that to monitor PrEP and PEP use throughout the state, we want to ensure that these interventions are available to all people who would benefit from them throughout the state. And that in order to do that, we need to develop new data and program evaluation systems to assess the uptake of these interventions by population and geography. So to do this, we're collaborating with our partners in San Francisco and Los Angeles to monitor PrEP use in San Francisco, Los Angeles, and San Diego using the National HIV Behavioral Surveillance Data, which is a CDC-funded behavioral surveillance system. And then we're also partnering with our partners at the California Department of Healthcare Services to monitor PrEP use among Medi-Cal beneficiaries, because Medi-Cal now covers about 1/3 of the state's population and fully covers PrEP and PEP. So we are looking forward to continuing to partner with the legislature, the community, local health jurisdictions, community-based organizations, medical and non-medical providers to ensure that all Californians who might benefit from PrEP and PEP know about and can access these important interventions to prevent HIV. Many thanks. So I don't know if I was open to questions now.
Let's give Dr. Marks a round of applause for her presentation. Thank you very, very much for that very comprehensive presentation. I would like to start off by asking a question, but before I do that, I want to also underscore that this is a very, very important topic. And I think that a remarkable feat is taking place right now where you have a Democrat as well as a Republican who are solidly on searching for answers and trying to create a plan, a statewide plan to address this particular issue. And so I want to pause and again express my gratitude to Marie Waldron for her support and her advocacy around this particular issue. It's always good to have a friend in the legislature, especially those who may be on the opposite side of the aisle, who will also agree to work towards this particular end. And so I appreciate her staff as well as her commitment and her family's commitment, because her brother is a well-renowned doctor in this particular area. And again, I just wanted to show my appreciation that this is a bipartisan focus. It's which will need a bipartisan fix in the legislature to come up and to help fund continuous efforts to get to zero new infectious cases in California. So again, thank you very, very much for your help and also your support and commitment to this end. So with that, Dr. Marks, again, I want to say thank you very much for your presentation. Can you just talk about your collaboration on the local level as well as the state level with key stakeholders around development of a plan and getting to zero, and what that plan looks like, and where are you with that plan? Because it's important that these hearings that are taking shape and getting community input and things of that nature across the state is combined with your efforts so that we can come out with one united voice of California.
So thank you for that question. So we are working with local partners throughout the state, including our local health jurisdictions, community partners, and people living with HIV and at risk for HIV, to come up with a plan for California that will help get us closer to zero. And it's a surveillance, prevention, and care plan for the state. So we've had a number of community meetings, and then of course I've also attended the meetings that you have organized to hear community input. We organized a meeting in Sacramento back in April that included folks from throughout the state, as well as a meeting in Los Angeles. So we had a Northern California meeting and a Southern California meeting to get broad community input into the plan. We also committed to releasing drafts of the plan for community input to make sure that what we have put forth really gets all the best ideas from everyone throughout the state. We actually have already released a draft of the goals and objectives, and we got really great feedback from people throughout the state on those goals and objectives. And actually later this week, we will be releasing an early draft of the plan. Again, it's not by any means finished, it's just an early draft, but we committed to really releasing an early draft in order to give people plenty of time to look through it and put their minds together and give us the best possible feedback into it. And then once we get all that feedback, we'll work on finalizing it, and then it's eventually due to our federal funders on September 30th.
Fantastic. When you have a conversation, when there's a conversation that's taking place about a plan, one of the concerns or one of the growing conversations in California is around homelessness. And do you have data to suggest how many individuals who are homeless, who are also infected, who also needs, PrEP and PAP?
So we are putting together, as part of this process, data on homelessness among people living with HIV. I don't believe that we have any data specifically on homelessness around people at risk for HIV, who might be good candidates for PrEP and PAP. But the overall plan includes a needs assessment, so it includes a process of looking through all the data that we have and putting that together and presenting that as well as the plan. And we are recognizing that homelessness is a huge problem throughout the state, and it's a problem that really affects people's ability to take their medications. So we are addressing that as part of the plan.
Because in California, in the legislature and the assembly side, there's a growing conversation that we are having around homelessness and trying to address it financially, but also continue to create a funding stream that will not be where we're putting a Band-Aid on homelessness, but addressing homelessness from a very serious standpoint. But I don't want to forget about those who are homeless, who are living with this disease as well. So we should make sure that's part of the plan moving forward. So I want to pause here and ask my colleague to weigh in to any questions she may have. I'm sorry, yes.
Thank you, Mr. Chairman. Very thorough presentation. I know there was a lot of information you had to kind of, get into a smaller space, but one of the issues I've had to deal with when I served on Public Safety Committee as well as Health Committee is the prison system, and now with realignment, now the jail system, county jails, and the services provided there. Will the plan, or how are you working, or what is the status of treatment or even preventative treatment in now jail systems? Is there any, I know that services have not been the same as they were in prison.
Yeah, so we are working with all of our state partners on this plan, including CDCR, because we do recognize, particularly around people being released from jail and prison, people living with HIV at the time of release from jail and prison, there's a real role for making sure that there's a good transition in terms of going from the system of HIV care that exists when people are incarcerated into the community system of care. So we are looking at that very carefully and making sure that we're addressing that.
Yes, and one of the things we also, being a member of the Mental Health Caucus, was that comprehensive care, because we're dealing with not only HIV, but, the mental health aspects, counseling, TB, and hepatitis C, which seem to kind of all work together within the prison and the jail systems, and, that's something that we continually work on in Sacramento. So
Great, thank you.
you for that. Just really quick, I have included in the packet, but it's from 2014, so it may not be updated. You might have better data. It's indicating that the Ryan White funding to California had dropped since 2012. And I'm wondering, is that due to the ACA, or was there like a backfill of funding from some other mechanism through ACA? Or it's just that this slide here is showing that there was a drop from 2012 in Ryan White funding and general aid support and funding.
Yeah, so I would probably have to look at that more carefully and get back to you. I do know that as part of the federal sequestration, there was an overall drop in Ryan White funding that happened related to sequestration, as with many federal funding programs. We get a portion of the statewide Ryan White funding that comes into the state, that comes to CDPH, that is for ADAP, as well as for the state as a whole. But then there are also other parts of Ryan White funding that come in directly to counties and other parts that go directly to clinics. So it's a little hard to, without taking a look at all the numbers, to give you a definitive answer on that.
Yes, thank you. And I'm glad that you mentioned in your presentation about the data-driven, looking at the various groups and using the data, because more and more being able to use data in analyzing various groups and how diseases affect communities is really important in our ability to be able to outreach and to actually have effective treatment. So thank you for that.
Thank you.
Thank you very much. I want to ask one other final question. In what way is the epidemic in California similar and different from other states that have developed or are developing plans?
That's a great question. So there are many commonalities, but also differences in the HIV epidemic throughout the U.S. So on the West Coast as a whole, we have a higher proportion of people living with HIV and at risk for HIV who are gay and bisexual men than, for example, in the Northeast, where there was a lot more HIV transmission through injection drug use than there ever was in California. And then in the South, there's more heterosexual transmission of HIV than there is in California. Obviously, there's heterosexual transmission of HIV everywhere, but it's a larger proportion of their new infections compared with California. So there are some demographic differences throughout the country, but also a lot of commonalities.
Thank you very much. At this point, we want to open up the public, this opportunity for the public segment for your comments or questions that you may have for Dr. Marks regarding her presentation. So if anyone would like to make a comment or a statement, please, the microphones to your right, to your, my left, are made available to you at this point in time. If we have none, we're just going to keep on rolling. Anyone have any questions? No. Okay, great. Let's thank Dr. Marks one more time for her presentation. Thank you very, very much.
Thank you.
We appreciate it. Next, we will, for a discussion, focus on HIV preventative medication and how we can begin to increase awareness about the treatment. We will hear from a panel of experts in their various capacities in the community. Each panel will have 15 minutes to speak. We would certainly ask that you introduce yourself with your name and your organization, and then move forward with your presentation. We will begin, I can't see, Mr. Moore?
Yes. Did you want to come to the podium, or do you want to speak to me?
Do you have PowerPoint?
No, I don't.
Okay, feel free. Whichever is comfortable for you.
Okay. Turn this on. Is this on? Yes. Thank you. All right. Am I free to go now then?
Yes, please.
Oh, thank you.
Dr.
So
Morris.
I'm Sheldon Morris. I'm an associate professor here at UC San Diego in the Division of Infectious Diseases and in the Department of Family Medicine Public Health. And my specialties are actually in primary care, family medicine, and also in preventive medicine. And my experience with PrEP is that, in particular, because I've been doing research here now for almost 10 years. In the past 5 years, that's been focused on pre-exposure prophylaxis studies, which I'll talk about some more. I mean, just to give you more perspective, I mean, this was in my first sort of career. I've also been in sort of primary care for 25 years, and I've worked in health departments and setting up programs for youth, reproductive services, for hepatitis C treatment, methadone maintenance, HIV treatment, and trying to integrate those things in the public health level, and also trained in, both in county health departments and at the state health department in STD control before coming here. So I've kind of seen a broad spectrum of the way, medicine is practiced and delivered. And in my current setting, of course, I'm more in an academic setting where I'm primarily doing research and seeing primary care patients that include HIV care and HIV prevention through our sort of family medicine program here. So, is this a better one? Oh, yeah. That sounds much better. So, a little bit more about where we've come from, and I think that in many ways we've been sort of one of the leaders, I mean, in terms of the implementation side of pre-exposure prophylaxis, because my research group, I'm a director of a sort of Southern California-based HIV research group called California Collaborative Treatment Group that has, in the past 4 years, provided implementation study in 400 men or sex with men in Southern California, in Los Angeles, Long Beach, and in San Diego. We just completed that study, and we're currently also now enrolling 135 women, both in Los Angeles and San Diego, and in the next 4 years we'll be doing 300 transgender individuals also across Southern California. So this is very much what we do, and have some sense of the pulse of what's going on in that, and what the sort of upcoming issues might be. And PrEP, we were some of the first people to sort of establish sort of the idea of the navigation of PrEP, and actually Marvin's done some of that for us. So, and when we're looking at the question of what's the most pressing issue facing California in terms of PrEP and PEP, I think it comes down to sort of the knowledge of the, that these things exist, and then being able to access them. I think they both go together, and that is what we sort of experience. Although I think California itself has been a leader in terms of implementing, the insurance plans and getting people on insurance, because we've certainly seen that in our group, where we have about 90% of our study subjects have insurance ongoing, although some of them change it year to year. And so we found coverage to be less of an issue, but there's still gaps where people have had not had insurance. So one of the most recent things we did is when we finished our research study, where we were providing pre-exposure prophylaxis, which is Truvada, we had to link them to community providers. And we were very successful in that. Most people had insurance, and who wanted to, we could, but there were people that did not have insurance or did not have access to it, and we saw people get infected with HIV, at least one case. And one of the things that have come out from what I've been doing in terms of people who either deferred taking prevention medication or who dropped off study and said we don't want to take it anymore, is that that's where we saw people getting HIV. And so I think one of the more future problems is going to be is not just getting them to find access and find providers and getting prescriptions, but is getting them back and keeping them on it. And sort of like that birth control allegory, most women continue to take it even if they're not sexually active. And in this case, I'm wondering if we have to keep people engaged, because there's been sort of some thinking, the risk changes over time, and so people go off and off, on and off, perhaps maybe because they may not always need it. But what we're finding sometimes is those people don't come back or don't realize when they need it again. That's just sort of our most very recent things that we're tending to find. I think that everything that Dr. Marks mentioned, these are all things that are just tremendous ways to improve it. I think the navigation is a real piece that we've identified in the past, where people don't know where to go. And more importantly, what do they say to their provider? Because oftentimes providers don't necessarily know what it is and are uncomfortable prescribing it. And so creating a script of here's the things that I need. And that goes to the thing of the knowledge, I think, speaks to that. If people know about it and see themselves as someone that needs it, they'll go ask for it, and that will drive it. That's the supply-demand side, right? So people who are demanding that they're eventually going to have to, the physicians have to meet that demand. And I think in a way we do have a very targeted population in Southern California in many ways, because we have such a large epidemic among more MSM. But I also see the benefit of making a broader knowledge, and campaign that would help in terms of getting to everybody in the population. I hark back to when I did this adolescent reproductive clinic, how many young teenagers were asking me for HIV testing. And in the community that I worked in that health department, the risk of their HIV was extremely low, but yet everybody had heard about it and were asking about it, and that drove us to test them. Although we sometimes made judgment around, whether this person really even was at any risk whatsoever. But now with, and that's what we were demystifying HIV testing through the guidelines. Your guidelines tell us that anyone should get HIV tests, right, at once in their life, who have their and that destigmatizes the HIV testing. And if we can get to that point where young people are coming to me and saying, should I be on PrEP? That would be really great, because then, even if they're not, but then when the provider interacts with them, they can tell them, well, really, this is not something that you need. But if we get to that level where everybody knows about it, that I think would be a huge benefit, because it's not so much that we're targeting population. I think it also needs to be, the message needs to come out in different ways, because as we've now progressed to seeing women and trying to get women on pre-exposure prophylaxis and our transgender, we find that these are very unique populations, and the message you give is different. And for example, identifying women who are at risk of HIV is a little tricky. They often do not recognize, self-identify themselves as risk of having any risk for HIV. So there's a lot more broader sort of scope that we've done in terms of advertising, and then trying to work out, are this person really at risk, and what are those factors that they really would need it. In the end, if people really want it and they see themselves as being at risk, I tend to always, agree with the patient. And that's what I would do in my practice as well. But, so I think that the message has to go out in different forms, but it needs to reach, Latinos, it needs to reach African-American populations, it needs to reach transgender populations, and not blanket them together. One of the biggest comments that we had when we had our study enrolling in the past few years, which was inclusive to transgender male to female, was that we don't want to be part of another men who have sex with men study. We want our own study, and that's why we have our own transgender study coming up. But each of them see themselves as unique populations, and they each need different messaging. But if we can get that broadly out to people, I think that would be the way to get the knowledge out there. And that's, addressing sort of where we get to the general public's idea, where they're actually asking for these things. What would be, in terms of getting the providers, and providers who, when they get that demand, are going to eventually try to learn, or at least have some mechanism. One of the problems with our health system is the siloing of all our services. You have a silo for where your health insurance provides care for, there's the health departments, and it's hard to work together. And in terms of, if someone in one provider group doesn't know anything about it, where do they send that person to get it? It's simple enough, but some providers still would feel uncomfortable possibly giving it for a number of reasons, and they should be an outlet for them to go. And that I struggle with that because of these siloing. It's very difficult to get it. I get, they call me from the health department to see patients sometimes, and it's such a difficult thing to access. You sign up with a new health plan to that health system, get in and see that provider. It can take, just weeks and months to come and see me, and I feel so bad about that. But it's more this, it's the system of how it works, and in things like this, prevention and it's teaching them in the moment that really, they think they need it right then and there. You want to provide it right in there because you're taking that opportunity of when they see themselves all of a sudden ready for action, and you want to be able to act on that. And that's one of the problems both with, I think, both the PrEP and PEP side, where the access is, it takes too long. And with PEP being driven, for example, by a lot in some communities by going to the emergency, which can incur a big bill for those people, where it's just a simple prescription. I know in my practice, if they're an existing patient, yeah, no problem, just call me and I'll, we get it done. But for people that haven't access that, it takes too much. There's a lot of cost barriers, and I know even here, we still are cobbling together a post-exposure prophylaxis the way we expect. We have to use donated drugs and things like that. So that is, I think, a big problem in terms of, I think, PEP that is unique with post-exposure prophylaxis is still getting that covered. If you have an insurance plan, it seems to be fine, but people that don't have that don't have an easy access. And I think it'd almost be nicer if they could have a direct connection, like a pharmacist's prescription almost. I don't know if that idea would fly, but just ways that if people have an HIV negative test, because there's it's a little complicated, right? They have to be tested negative, they should have follow-up, there's monitoring of drug. So there's a lot of things that it gets done, but it complicates it, and certainly the biggest problem with PEP is really the coverage aspect of it, and why we are still having to figure out ways to get free drug for people to cover them until they can get a prescription. It seems to me that system, there should be a final fix to that. Pre-exposure prophylaxis is a little bit better. We have not encountered as much problem people getting, but there are gaps, and like I mentioned, where people couldn't get it. And that's where this ADAP sounds like a wonderful idea. That's really what we needed, fill the gap of where it is. Because I don't think it's going to be a lot of dollars. I think a lot of people have it and they'll get covered on their insurance. And some of the things to accomplish, I think I'm not sure why insurance has been so good about it, and I'm so glad that they have been. One is that it's FDA approved, which PEP is not, but they usually still get PEP covered. Another thing is I think that there are some mandated rules, and one of the things is that they're supposed to cover U.S. Preventive Services Task Force A and B recommendations. So last year I sponsored it to be reviewed by U.S. Preventive Services Task Force for pre-exposure prophylaxis, because if it became an A or B recommendation, it automatically should be paid by insurance. They did say it was within their scope, but they said that they are waiting for some other studies to come in. I'm not quite sure what studies they need, because I think our studies we have are very excellent already. But that's the kind of policy part that would really help implementation too, is getting it into the mantra of practice. So, if we can eventually get that as a A or B recommendation of U.S. Preventive Services Task Force, that gets fed down to providers that this is a recommended thing. And obviously CDC has come through very quickly with guidance. They came through within the first, even before PrEP had been officially approved or Truvada had been approved, they had guidance on it, and then they came up with additional guidance. So from the public health side, the response has been, I think, has been quite excellent. But getting now into, I think getting it also into other guidelines. So now we have good, guidance around PrEP for what we perceive as HIV infected, but also I think it should be tagged along with STD guidelines, with any sort of other guidelines where these risk populations may persist. It should be part of their routine care. And I think the routinization of offering these services might be one of the things to break down barriers. I still hear from very seasoned HIV providers, well, I'm not sure that that is cost effective as we don't have everybody that needs to be on therapy, as we saw with those numbers in terms of suppression rates. But I also see that, that's going to be really hard to get to. We're at a much easier part of the prevention side, because there's a lot of people out there that could easily be flipped into doing it. And I'm not so, I wouldn't get so fixated on the cost implementation side, because I think it's like a forest fire, right? I mean, if the fire's burning, and those are the people with HIV, we know that's where it's coming from. You're saying, well, let's douse that fire. But what do we do in forest fires? We have to go dig the perimeter. There's the prevention side is a big piece of containing a fire. Unfortunately, we have a lot of experience with forest fires now in California. But we need to be doing that work too if you want to achieve stopping the fire, correct? You really need to get to the barriers and prevent it from spreading. And I think it's very so effective, and that's what we've seen in our personal, not just from the data, but when we've done our studies, we see that people that took it, they don't have HIV. People that dropped off it or decided not to take it, they got HIV. And it was so striking to me that how effective it has been. I think some of that getting to the providers is also, I know they asked me to, with the California HIV prevention sort of training center, I know I'm going to go talk in Orange County, I think, in next month. But that's one of the ways to do it, is just to expand in those different kinds of ways that we can educate those providers. And I think, again, Dr. Marks presented a number of strategies that are very effective. So I think in the end, I think what other things can we do to accomplish these goals? Well, I think the comprehensive plan needs to be improving that knowledge across the overall the state, providing these systems to provide the access. Coming up with some bigger solution for PEP, I think, is really needed in terms of making that a solid effort, because PEP is sometimes the gateway to PrEP, right? After that person comes for PEP the second time, or even the first time, I'm saying, shouldn't you be thinking about being on prevention if you're going to be needing this? And so that getting them into even coming in for post-exposure prophylaxis is a way for them to enter care so that we can provide further prevention services. I think that covers all the points I was going to make. So I could stop there.
Thank you very much, Dr. Morris. I have a few questions for you. If I can find where I wrote them down there. Oh, okay. Can you just touch briefly on your experience around those who start and stop treatment? Because I'm alarmed by that in terms of people will start it and then for some reason just stop treatment when it's recommended that there needs to be continuous treatment in terms of taking such treatment. So what has been, from your standpoint, have been an excuse or why they would actually stop treatment and not continue on? Is it lack of funding or exactly what?
I think it's more, most of the reasons that they stopped our study was because they chose not to take it. And what we're dealing with is a slightly different group than we see with HIV-infected individuals. They do not have a disease. These are people that are generally very healthy, on no medications. And, just think of, I don't know if anybody, you guys are on blood pressure pills or anything like that, but, when I see patients, and just getting the people in their 40s, 50s on their first prescription drug, they're very hesitant. They go, I don't like prescription drugs, and they always come back and your blood pressure's still high. You really should go on something. And so there's that mentality that we don't want to be on medication. So some people don't like being on the medications. They're worried about side effects, and then they don't perceive themselves at risk sometimes anymore, or they find it just the process, because they're already so healthy, to go through all the hoops to come to the clinic every 3 months and get tested and get all those things to them, it starts, there's this balance that they're saying, this is just not worth it, because it's maybe a little not as tangible to them what the end result is. There's also a little bit of controversy just being driven by the research itself, right? So there's been episodic studies to use sort of event-driven pre-exposure prophylaxis, so people would take it just before they're sexually active. And there was a very successful study where they did two doses before sexual activity and then 2 doses after, or daily, or once a day for there, so 4 doses. And that was very successful, except that most people were taking at least 4 doses a week, which we consider to be sort of adequate dosing to actually do for long-term prevention too. So whether or not the episodic dosing really works is uncertain. Other studies where they did episodic dosing in other countries and things found that a lot of people just forgot to take it when they needed it. So event-driven dosing, I think, probably works, but it is much valuable in terms of their overall implementation. So some of the patients are getting mixed messages of really, do I need to be taking this on a daily bill? Also, the data would support that if they're taking 4 or more doses a week, they're probably getting 90% protection. So they hear that message, and then they may think that maybe they don't have to take it. But
So, I'm sorry, so how do we begin to, one, because you touched on something that I want to touch on, educating doctors that see someone that may be at high risk, to provide information to them, and then 2, dispel some of the myths and the rumors out there in terms of you take it 4 days a week, then you're 90% covered, but that's not in fact the case. So how do we begin to try to create an atmosphere that is providing reliable, knowledgeable information that people can use and also live a long life?
yeah, I think the way
With
to do that.
doctors and also individuals.
So probably, the big message there is that people should be taking their medication as prescribed. I think that's a message we often give people for generally a lot of things, but it also holds true here that, the approval for Truvada is daily dosing. And even though, the way I explain it when I talk to a patient, I go, okay, if you miss a dose, that's not a problem. Just take your next dose. If you're missing more than a week, though, or then we should really do another test for you. And it's a very similar birth control pills in terms of like this overall management of missing doses and stuff. So we need to also create those sort of ways in our teachings to the physicians, and probably a update and guidance might be helpful too, to say that this remains a daily drug. I mean, the field's in flux a little bit in terms of what that'll happen, but I think this is sort of my opinion in terms of that we need to stick to the once daily dosing as the way to go, and that's a very unifying message rather than being, it can be like, then it gets people get confused. So I guess a lot of that kind of ends up with the provider, because I think when we do the broad-based sort of knowledge building in the community, it may be a bit too of a fine point actually to try to transmit in a media campaign or any way, although I think that they can read the smaller details if you provide them through adequate links and stuff, but the provider probably needs to be where that has to happen.
One final question. I think it's my understanding that as teachers have to have continuous training in your profession as a teacher. So I would assume that the same would hold true for doctors. So would it be at that particular point where that continuous training or education is given, that this information is given at that particular point in time? I don't want to create policy for you or put you in a position, but we have to be able to get this information into the hands of the first responder, and that is, I believe, is the doctor.
Yeah, you have a good point. Well, I think that a lot can be driven too by their, HIV prevention goes beyond doctors. There's a lot of HIV testing people. This is another challenge with it, is that because HIV prevention, it crosses over many disciplines. But yes, so people have to take updated trainings for all their specialties usually, and they go to conferences, they update their clinical skills. So they need to be infiltrated into those things to provide those things. And this is where I can go back to my primary care hat and my experience in dealing with them. that HIV for a lot of primary care docs is this little part of their world that they don't even really think. It's heart disease, diabetes, and when you start talking about that, it's hard for them to listen because they don't see it as their big priority sometimes in their practice. So sometimes getting that message, even when I go to, again, I go to the prevention medicine things, it's a small part of what they talk about in terms of the broad spectrum of prevention things. So we have to bring it up as an important agenda item, and that should be addressed in all the conferences. And whether you can mandate, they do mandate some things, but I don't know if I'd really go that far to make that, call.
Member Waldron?
Yes, thank you, Mr. Chair. Just to kind of tack on what you were saying, Dr. Morris, you had mentioned something about a task force, I didn't get the name of it, that looks at, what some of the requirements would be or guidelines, and that the CDC had come out with some, but there's still, this task force might be able to look at some of those guidelines and maybe incorporate into routine care like STDs and things like that, these guidelines, so that physicians, especially primary care, would be able to see them. One of the things we had met in our office with the LA AIDS Project, and they were saying seems to be still a little bit of a stigma among some primary care doctors to even deal with the HIV issue. And, when you have folks coming in and they're negative on their test, but it's the perfect opportunity to get them knowledgeable about PrEP. We've had these issues in our health committee where we try to, encourage, it's not really the legislature's role to encourage what a doctor tells their patient, and it would be more this task force, I would assume, getting that information out there would really go a long way, or opening that dialogue between the patient and the doctor so that stigma is not there. And do you see much of that anymore, or is that, how could we, just tapping onto what Chairman Gibson said, getting that dialogue between the primary care and the patient, when they're face to face?
Yeah, well, that's why I think the destigmatization happens by, having everybody in the conversation. So that's why, even though we may be marketing to people that we don't think are at risk, that's somebody's sister or mother. And so the message comes around, and that normalizes it, I think, a lot more. Sure, we see that kind of bias in physicians. These are human beings, and some of them hold biases, and I not entirely because of personal reasons. I mean, there's probably still some of that. And I tell patients, well, that shouldn't be your doctor. You really need to find somebody else. But the other thing is just these competing priorities where they don't see it as being as much a priority. And what makes things a priority? Well, yes, making it guidance, and that's why the Preventive Services Task Force is a sort of independent group that's kind of funded through the government, but it sits over there and they kind of deliberate all the evidence to decide what is the best things. For example, should you give aspirin for colon cancer prevention? So it's all about prevention services. So those things that we do need to penetrate those things, because that's the first step. And then they have to actually implement those things, and some of those things are not that easy. So what happens at our, for example, university level here and in our practice, we have to, they actually, measure milestones. So like, did you order cholesterol on how many of your patients, and how many people are in hypertension control? I mean, they don't have any of those. STDs, HIV does not occur in any of those metrics, but if they became a metric for people, then it becomes something they need to track. And I know at one point they made chlamydia testing, I think, a metric for some insurance companies and for performance of HMOs. And so people started paying attention, and they said, well, we're going to start doing a lot more chlamydia testing for the appropriate populations. And so that's where, you can make differences if it penetrates to that level where it becomes a metric for their performance.
Mm-hmm. Just a follow-up, as far as PrEP, are there any side effects? Has it been deemed to be relatively safe from everybody?
Yeah, I would really say that this has been surprisingly well tolerated. I think you generally see, in our large cohort of people, we see some complaints of GI complaints of it, and people just don't like it right off the beginning. But even if they persist through that, they often actually tolerate it very well. And we were actually we had one actually major adverse event, which has not been seen in the previous PrEP studies, which was a kidney-related problem called Fanconi syndrome, but it did resolve once you stop the medication. So it's not like put it in the water. That's why the kidney monitor becomes really important. So even if you cover the drug, they still need to have these other sort of minimalist type of chemistries done to get those very few cases of these things that can happen. But in the grand scheme of sort of medications, these are remarkably safe medications from what I've seen.
Mm-hmm. And I've heard some people indicating, and I know it's been debunked, I think, through the studies, that using PrEP would lead to riskier behavior, and that has not been an outcome. Is it?
Well, it is and isn't. I think that there is some, and we haven't published that yet, but it's not. The thing is that if they're taking their medication, they're broadly protected, and that's got to be the overlying theme. There are some people that might use that to change the way that they interact with other people, but that in itself, it does not necessarily lead to any new HIV infections for sure. I mean, you could make the argument that they're STDs, but we don't really see a big difference in it. STDs are super high in this group generally because they've self-selected as people that are high risk, so we've seen very high, and I think all the people doing PrEP studies have found very high rates of STDs. But one thing is they're finally getting tested. The other thing is that they are a select group of people. But is that in itself a danger? I don't think that most risk behaviors don't go up, but there are some things that do change. One of the things we're trying to move towards too is measuring an improvement in quality of life, though, because people lived in fear before, so you get the personal sort of anecdotes like this. When I went in to get my HIV testing before, I was always terrified. Now I go in, I'm not worried about it. So it's their life, the quality is much better because now they don't have to live in fear anymore, of it contracting HIV as much.
Thank you very much. Certainly appreciate that. Next, we want to move to Marvin Hashiro. Thank you very much for joining us.
Thank you. Good afternoon, everybody. So my name is Marvin Hanashiro, and I actually work as a research associate with Dr. Morris in his lab. So a lot of my experience comes from working directly with participants and individuals, mainly in PrEP navigation, as well as linkage, and some on the PrEP study as well. So also, I'm a consumer of PrEP myself. So I kind of speak from both perspectives as both like the researcher slash person taking PrEP. Now, I think as far as like answering some of the questions for like maybe recommendations for increasing the general public's knowledge, in my experience, I feel like though it comes in two parts. One, I think there's still quite a number of judgment and shame that people are in the community are passing on to each other for people taking PrEP. You just mentioned it a little bit earlier, just that there were some studies or some indications that people may engage in riskier behaviors once starting PrEP. And so I feel like that's a conversation that I hear constantly. I've been told things myself by, well, if you're taking PrEP, then maybe you are doing more extracurricular things or whatnot, which I say, this is something that we're doing to protect yourself. And, we want to empower ourselves and take control of our sexual health. And so instead of passing judgment on someone for doing something proactive, we should be empowering each other to congratulate, say, like, if you're going to do something for you to protect you and the community as a whole, why not embrace that and applaud that versus shaming each other for doing something. Generally, it's going to be a positive, right? So that's kind of one of the major things that I'm still hearing today, even after 3 years of the drugs being out. The other thing that I find a little bit alarming is, especially working on the PrEP study, a lot of younger MSM, I feel, kind of don't think HIV is a huge issue as much. So socially, they know it's there, but I feel like they're like, oh, I can just take a drug and I'll be fine, which is great. With the medications we have today, of course, people live long, healthy lives. But in general, I feel like there's a complacency that younger people are thinking like, well, it's going to happen. If it happens, then I don't really care. And I'm like, well, we should probably change the vernacular about that, right? And that we should care. This is something that's preventative. You don't have to get HIV. So we should talk more in that vein, versus it's going to happen. No, it doesn't have to happen. And so I feel like maybe like a social campaign, both on those issues, both on, not anti-shaming, more embracing PrEP as a preventive strategy, and then as well as, trying to re-educate younger generations of people that HIV is still an issue, still a major issue. It's not going away. We see the numbers are either in parts of the country either staying the same or going up. So, which is sad to me. Something that we have all the tools that we have today, yet the infection rates aren't going necessarily down. So as far as like social campaign, I feel like definitely pushing more things on social media, even public radio like NPR for people. I listen to NPR, so that'd be a great tool for people, especially that are maybe 30s, 40s that want to get into PrEP, 50s, right? And then I think another thing too that I've encountered with a lot of the study participants is a lot of people I feel like have a fear of talking to their doctor still. They feel like they're going to be judged. They feel they may not have the medical knowledge, and so they're going to listen to what their physician says. Take them as the expert, of course. So I feel like I don't know necessarily how to do it, but having some kind of way to educate and help empower patients to advocate for their own sexual needs and sexual health needs, I should say. And maybe having conversations and role plays, and maybe that could be a role of like a PrEP navigator at a county health center, county health testing site, or other areas where they can work with someone to help them figure out the conversation that they can have with their doctor. So for example, with one of our studies, which we did the PrEP linkage, what we did was we would work with them, talk about adherence, talk about protocol, talk about the clinical guidelines when it came to taking PrEP. But then I'd also say, well, if they mentioned they were uncomfortable or nervous speaking to the doctor, I'm like, well, then let's just talk about it here. I'll be the doctor, you be yourself, and then let's just kind of role play this, just to kind of work out questions that they may have or insecurities that they may encounter, just to at least so that when they're ready to go, they're more prepared. They feel a little bit more like empowered, of course. And then I said, I put a note that a lot of times I feel like patients, we have to acknowledge that they're sometimes even coming out to their doctor, especially MSM. So a lot of times, they're like, I go see my doctor for general health checkups, but they don't really know much about my sexual history or that I'm even gay or whatnot. So I feel like part of that navigation, the PrEP navigator role could help with, just acknowledging that this is going to be a coming out process for you too, to your physician. And so that kind of like reliving some of the things, the struggles you probably went through when coming out to family or friends or whatnot, And then I think like a biggest thing too is, we saw in Dr. Mark's presentation that a lot of the new infections today are coming in from people in their 20s and 30s. And so I feel like if we're going to do targeted marketing or campaigning, it needs to be done in younger age groups, like high school age, to try to get the message early on, because it's going to take a while for that message to really sink in. So it needs to start in high school and then keep going through college. And then in order to help prevent the 20s and 30s infection rates from happening, it has to happen like a decade earlier, as far as the marketing pushes, I feel. And so...
So, I'm sorry, Marvin, if I can interrupt. You made mention of a social campaign, because I know that if you would just say that Pokemon is going to be somewhere on campus, you're going to find everyone with their phones looking for Pokemon. It's just a crave, and so they are doing it well, and they're bringing in, I see older as well as younger individuals looking for this little Pokemon kind of thing. out there. But if you would look at the campaign in which they're using, it is drawing people in a rate that I haven't seen before. I mean, I'm at a restaurant last night in Santa Monica, and there were people looking for Pokemon at the restaurant down at the pool. And so you saw droves of people going down to the pool. I guess the point I'm trying to make is social media is a wave of the future. And you hit on something in terms of touching on Dr. Mark's presentation, that age group, the 20 to 30, and that's the 20 to 30 age group that is socially conscious. So what would you say that we should be doing or advocating to try to drag them in terms of Facebook or what? How do we frame that conversation?
Well, yeah, I mean, it's probably a good question for a marketing team, right? But basically, I mean, I think as far as the social media platforms, you know, definitely Facebook, Instagram, you know, there's also the gay dating apps that are out there that definitely allow advertisers to, you know, send messages and whatnot, so that'd be a great avenue as well.
They don't do it now?
They do it now,
Oh, they do it now.
but I'm saying like to continue that, you know, that avenue of advertising and whatnot. And then I think when I said social campaign too, it was addressing part of just the shame and the stigma that comes with taking PrEP that I feel that people, like I said, put onto others. And so as for the social campaign, you're trying to destigmatize that aspect so that people don't feel uncomfortable or they don't want to be judged. You know, because I have even some friends who aren't publicly out and don't tell people they're on PrEP, even though they're taking it, because they just want to avoid the conversations that they are going to encounter with people, and they're basically saying like, well, why are you doing that? Like, it's something that, is it allowing you to be more promiscuous or whatnot? Which is, you know, these are judgments that we don't need to pass on to each other. So I feel like a social campaign, as far as just trying to, you know, address that issue, I think would be really helpful. So we can change the dialogue and put it in a more positive tone versus a negative connotation. So that's kind of where I was coming from. Now, as far as recommendations for like healthcare providers and whatnot, I mean, you know, Dr. Morris and you guys already mentioned that I know the Office of AIDS are going to be addressing, you know, doing like seminars and whatnot. So I feel like, you know, there's still, I forgot what the percentage is, but it's still only about like 30% of providers or 30 or 40% that actually are aware of what PrEP is. And so, of course, there still needs to be a huge amount of education for providers as well. So, you know, as far as, I think it's great that there's going to be offering seminars. You know, I think as an incentive, I don't know whether or not they're going to be offering like CMEs, whatnot, so it actually gets the physicians to have to go, you know, so they can get some kind of payback for learning, right? And then I think it would be great too, especially with like, you know, the hospitals and the healthcare administrations, like to do like a mass, like at a hospital, saying like all the doctors have to come to this today, you know, kind of a thing. So you're going to capture like a lot of people at one time, you know, versus individual. It'd be harder, I think, to get like maybe the private practices, but at least you're going to get cover a lot of ground by, you know, working with like the healthcare providers in the hospital administrations and whatnot. So, and then as far as, you know, other recommendations for implementing these ideas, you know, I mentioned the CMEs, and I think I mentioned too that as a part of like sex education in high school, you know, PrEP needs to be part of the conversation now. And along with the HIV, when they talk about HIV, then PrEP should be with it. So that at least you're planting a seed in these younger minds so that they may not identify themselves as needing it now, but maybe in the future, it will come to a point where like, oh, I heard about that, maybe that's something I should be on now, you know?
Marvin, if I may interrupt, I was just reaching over, speaking to Member Waldron, and you touched on it. I'm not sure, because I've been out of high school for a long time, but I know that in sex education, the health class, they used to teach, and I used to have my parents sign a waiver so they can teach me sex education. Mm-hmm. One, are they still doing that in school? And is the focus still on, at that time, it was VD or, you know, gonorrhea and things of that nature. Is that still going on in schools?
Yeah, I think that happened because I have a daughter in high school, so I think I remember signing something as well.
So it still goes on. So one could actually, you know, I guess legislate this being part of a curriculum.
Right.
Again, going to what Marvin said, whether you need it or not, or even understand it, at least have the instruction or the education given to you moving forward. Because again, that's the population that is increasing.
Right. You know, and then along with the sex education classes, you know, just providing the tools for, like, you know, school nurses, counselors or guidance counselors, you know, since they're the other avenues that students are going to go see people with a health background per se. And then to continue that education in college. I know, like, Dr. Morris was trying to do a grant where we were going to work with the UC system schools and have prep navigators at all of the college, like the health clinics. And so I think that would be really important too, because, you know, definitely college age, sexually active, whatnot, you know, that'll be another avenue to continue that messaging with people. If they heard it from high school, then it'll continue in through college. And then I feel like two last ones. One is that, you know, I think it would be great too for, like, county health departments, especially the testing sites, if they had the funding and whatnot to even offer like a prep clinic, so to speak, so that while they're there being tested, they're already, you know, your mindset's already around the issues. So then that's kind of like a prime time to, like, grab somebody to be like, all right, they're kind of already open to the idea of they're being tested, they're accessing care to a certain degree. So then to capture that audience at that time, you know, just move them over to the next office, you know, for about prep. And then one thing we did learn too is, you know, it's great with the Medi-Cal expansion. You know, so many people are being covered now with insurance, and Medi-Cal covers it. But I found out too that Medicare doesn't, to my knowledge. And so when I was working with people that were older and on Medicare through the prep linkage program, you know, they were stuck between a rock and a hard place, because they didn't have enough. Medicare didn't cover it. They didn't have enough money to pay for it themselves, and that they didn't qualify then for any of the, like, financial assistance programs by the drug makers or the private ones. So they were just stuck. They couldn't do anything about it. So that we might have to figure out another way we can do another further expansion that hopefully Medicare will eventually start covering PrEP as well.
Let me just see here. Where did I? Now I've misplaced my note. Okay. Well, I like the idea of the PrEP navigator. I think, you know, that's something that is encouraging. And, you know, you were mentioning about the fear or the, you know, concern about when you speak to your doctor who may not know, you know, some of the issues. And being a woman, when you have an OBGYN, is a little different, because you're there dealing with reproductive issues. So it's something that, you know, they don't have any fear of asking all kinds of questions or, you know, getting people to talk. So I can understand the issue of educating a more primary care doctor on that type of issue, you know, and understanding this new, because when we have new innovations in healthcare, there's that kind of curve of time for people to understand, you know, the benefits of it.
Right.
So let's see. One of the things that it's just from June 2016, the American Medical Association saying that there's 1.2 million people in the U.S. at risk, but less than 5% are taking PrEP. So what you're saying is doing that outreach is so important, and, you know, just getting it out there. And I saw some ads on buses up in Sacramento dealing with that too. So, you know, we need young people like you to advocate on the best ways to reach young people, because as the technology changes, you know, it used to be more Facebook, now it's Instagram and all these other things that we don't even know. Is, you know, myself, I just see what my son has on his phone, but, you know, being able to access young people like you for your ideas and
Right.
how we can do that.
I think going along with what you said, also that something that Dr. Morris mentioned too is the self-perceived or your perception of your own risk. And so sometimes, he said like a lot of females don't believe they have any risks, but then I think still with MSM, they may say, in my experience working with participants, that they definitely go through seasons of risk, where sometimes people are, were very sexually active, and then they can go months without being sexually active. And so in those cases, and then people have a hard time wanting to continue taking a drug. As a reminder, I'm not having sex today. So, but to kind of change that conversation to say, well, if you don't take it constantly, then there's no room for spontaneity. And so basically, you just have to keep doing it just to make sure you're protected no matter what. So there doesn't have to be a fear like, oh no, I stopped taking it and I had an encounter which could have been risky. What do I do? Versus if they just continue to take it and encourage that line of thought, then that fear will start to drop, definitely.
So how do you feel, being a young person? Generally, young people don't feel like they really need to go to a doctor. It's not something they regularly would do. I mean, maybe they might get a checkup once every couple of years, So how do we get the word out or encourage young people that, they actually need to see the physician, because that's not in their lifestyle normally.
That's true. Well, I think and that's why definitely if the people aren't engaged in care normally, if they're young, yet they still will probably access like testing sites and whatnot, Because I think everyone or most MSM know you got to get tested every 3 to 6 months. It should be part of your routine. And so if you're going to tap that engaged audience there, that might be a good place too to encourage people to start having a prep conversation. So, and then saying, okay, well, have you ever thought talking to your doctor about that? Oh, I don't have a doctor. Oh, well, have you thought about getting one? Are there any other issues? Just engage in healthcare as a whole. But I think while you have people like at testing sites or like in our research or whatnot, that's probably a prime opportunity to encourage people.
At this time, we want to open it up to any of the public comments. So if anyone wishes to ask a question of our panel, this is the appropriate time to do so. Please take advantage of the microphones on either side, and please feel free. If they're okay, we have one.
Good afternoon, everyone. My name is Michelle Chambers, and thank you very much for all being here today, enlightening us on such an important issue. My question is regarding outreach. Does anyone know about any partnering with blood banks, Red Cross, or plasma centers or anything? I think that would be a great way to do outreach as far as HIV, as well as gay clubs or anything to that nature, pass on paraphernalia. Also, can pregnant women, and if you answered this already, excuse me, I had to step out. Can pregnant women take PrEP?
Thank you. Lester.
I can try and answer that. Yes, I think getting out to some clubs and stuff like that has happened. I think what was the first one, where to get out to?
Well, the first one was regarding
blood banks.
outreach.
Yeah, blood banks. I
partnering.
like that idea. And then in terms of the pregnant women, yes, we could give it to pregnant women. We treat women with HIV with the same drugs, and we consider them safe. Of course, there's a little bit of a different sort of risk versus benefit consideration there, because there's such a tremendous benefit from treating somebody that actually has HIV as opposed to prevention. So we do think of this more clearly, but women think about PrEP as, we call it prepception. They're thinking about trying to get pregnant, and that's another way to use it so that they are covered during the times they're trying to get pregnant. And then if they continue to be at risk during pregnancy, then there may be value in doing it as well. I guess it's an individualized assessment, though, and I wouldn't feel, I would feel comfortable giving it to a pregnant woman if I perceived her at being sufficient risk.
You said you would feel comfortable?
Yeah.
Okay, thank you all.
Any other additional questions or comments? Okay, hearing and seeing none, let me say thank you very much to our panel. Let's give our panel a round of applause. So this concludes our panel presentation, and we will now turn it over to me, who will give the final comment. I want to pause a moment and give my colleague, the co-host, Member Walton, an opportunity for providing any closing remarks before I proceed.
Thank you very much. While these preventative treatments are expensive, about $1,540 for 30 tablets, what we're finding is in the long run, there's actually cost savings. And that's one of the biggest issues we've been fighting in Sacramento, is trying to get folks to realize if we get the best treatments up front, we're saving costs in the long run, reducing community viral load, helping people have a better quality of life, and moving on with their lives. So, you know, I very much advocate for getting the word out on this. And thank you so much, Chairman Gibson, for having this hearing.
Thank you very much. When it comes down to, again, the costs, as Member Waldron has indicated, when these items go before our appropriation, they look at the dollar amount, but they don't actually look at the cost savings over a broad time span, right? When preventative measures are upfront and people can take advantage of those, that will far outweigh the cost of, you know, continuous office visits, medical expenses, and things of that nature. And so it's a whole educational process that needs to take place, even in Sacramento, even sometime among our colleagues. And I know that Member Waldron worked extremely hard trying to educate. She sits on the Health Committee and trying to provide reasonable conversation dialogue to our colleagues there around preventative medication. We have had a very robust conversation here today. I want to thank everyone for participating, all of our panels, and for the staff to help set this up, and to our physicians for your commitment to not only working closely with us, but also making sure that we educate Californians in getting to 0 new infectious cases in this state. Assembly Bill 2640, which is a bill that I have authored, and hopefully that it will be on the governor's desk sometime in August. It seeks to provide information to those who are high risk for infection, and providing them with information on PrEP and PEP. And so we're very hopeful that this will be signed by the governor, and that in healthcare facilities in California will be given this information to individuals who may be exposed and in high risk communities around HIV and AIDS. In addition to that, Assembly Bill 2179 is another one of my bills that I'm also authoring and very hopeful. This will reduce costs related to training non-medical personnel to administer the rapid test for hepatitis C. As you know, we believe they're interlinked, and the more information about hepatitis C, but most importantly, the cure that exists now in California for individuals, individuals can be tested, and 2, if they have in fact tested positive, they can also get a treatment and the cure that exists among us. I want to thank UC San Diego for allowing us to be here in this great facility. Dave and Zach, thank you very much. We appreciate you, Psalms, and everyone who have come out to be part of this hearing. To our panelists, again, thank you very much for giving of yourselves to be part of this robust conversation. And with that, we'll continue to now plan for our next hearing that will take place somewhere in the Inland Empire, where we will hopefully gather up all the information over these 4 statewide hearings so that we can, again, move the conversation through the legislature and hope that we can partner with the state, or we will partner with the state in terms of a white paper that California can wrap its arms around, and that we'll have our white paper to help get to 0 new infectious cases in the state of California. And so I believe that's all I have. Is there anything else? No? Okay. I want to thank Dr. Polk, Renita Polk. Many of you received phone calls from her, who has helped put this together. Let's give her a round of applause. We appreciate you. Thank you very much. And that will conclude this hearing. So thank you very much.